So just a reminder that this is an update to the original document, and the original document was published in 2009, and this is an update. So with the original document, everything aortic stenosis was looked at. With the updates, we're just going to do highlight some things that have changed over the years. We're gonna look at those. Also, as mentioned before, we have recognized that the flow across the valve is going to affect the velocity and hence the gradient. So there are conditions where you have a low flow situation, and the low flow is going to affect the velocity and the gradient. So you might get, by continuity equation, when you calculate the valve area, you may get a valve area less than 1 centimeter squared, but the velocity is less than 4 meters per second, and the gradient is less than 40 millimeters mercury. So this '09 document highlight, if you want to call it, that discrepancy and how to evaluate those patients with low flow. But when you're doing the continuity equation, as mentioned before, there are a number of things you're going to look at. You're going to look at the Lvot diameter, and that is done in the parasternal long axis view. You're going to go to your 5-chamber or 3-chamber view, and you want to get the Lvot velocity, and you want to get the aortic valve velocity. Those are the different parameters that you need to measure to calculate the continuity, use a continuity equation to calculate the valve area. It is crucial that when you're looking at the aortic valve, you have to use multiple acoustic windows, because you cannot just predict which site you're going to get maximum velocity and hence the maximum gradient. You have to use all the windows, the apical window, the right parasternal window, or the suprasternal notch view. So, if you're not comfortable in using these different windows, you need to get comfortable in using the windows. Also, it is important to don't mix up the MR, the mitral regurgitant envelope, with the aortic stenotic envelope. So you should be comfortable in distinguishing these jets, because they're both systolic jets. The MR jet is usually 5 meters per second or greater. And another thing that we use is that with MR, if you look at the MR envelope, the MR envelope doesn't have an IVRT, whereas your aortic envelope would have an IVRT or an IVCT. We can discuss that a little bit more, but if you remember, when you have when we look at systole, when you look at systole, then blood flows across the LVOT and hence the aortic valve, and that at the end of systole, the aortic valve closes. All the valves are closed, and there's relaxation, and we call that the IVRT, isovolumic relaxation period, where all the valves are closed, the LV muscles are relaxing, but the mitral valve is not yet open. Then the mitral valve opens and you get your E velocity. So when you look at your aortic envelope, you expect to get the ejection across the aortic valve, and you should get the IVRT. not the situation with mitral regurgitation. Mitral regurgitation, you're not going to get that IVRT. So that's one of the things you can use to distinguish between your aortic valve envelope and the mitral regurgitant envelope. But the MR envelope, the MR velocity is usually 5 meters per second or greater. Okay, so don't mix them up. It is recommended. The American Society of Echo recommend that you use one of the dedicated small dual crystal C-doubler transducer, the so-called pencil or PDOF probe. So they strongly recommend that you use that. It has a much higher signal to noise ratio, and you can position it and angulate it so you can get your flow parallel, the ultrasound beam parallel to flow. So it's not uncommon to get your maximum velocity when you're using the PDOF probe. When the velocity is low, however, less than 3 meters per second, you know, you may not, you don't have to use the PDOF probe. So when we talk about severity, when we look at the severe aortic stenosis, there are a number of things that you can look at. You look at the aortic stenotic jet velocity. So this is one of the parameters that will tell you about severity, the aortic jet velocity. And the cutoff for severe is greater than 4 meters per second. Okay, greater than 4 meters per second. And basically, it's a concept, you know, the narrower an orifice, if you have fluid flowing through an orifice, and we usually use the garden hose, if you narrow the nozzle, the, the water goes further, the velocity increase. So velocity increases as stenosis severity increases. This is a direct measurement, and you know, if you see 4 meters per second, you think about severe aortic stenosis. However, this is a Doppler measurement, and if you recall, your Doppler measurements are subjected to the angle theta, that is the angle between the ultrasound beam and the moving red blood cells. You want to get the ultrasound beam as parallel to flow as much as possible, because we use the cosine of that angle, and the cosine of 0 is 1, cosine of 90 is 0. Then we look at the gradient and the mean gradient, and as we explained in previous lecture, we use the mean gradient because the peak gradient just occurs at one point in time, whereas the mean gradient is throughout all of systole. And clinical the clinical picture is usually related to the mean gradient, and the mean gradient we use is 40. Okay, you can use this formula, but what we usually do is take the aortic stenotic jet, and once we do planimetry, once we trace around it, it will get a mean gradient. So severe AS velocity greater than 4 meters per second, mean gradient greater than 40 millimeters mercury. Okay. The gold standard is the continuity equation. So you have to use the continuity equation to calculate the valve area. And the area is usually expressed in centimeters square. You should know the formula. And the concept is the flow anywhere in the heart is going to be the same, and which is the volume per second. The flow is going to be the same. So the flow going across the LVOT is going to be the same flow across the aortic valve. Again, flow is equal to cross-sectional area times VTI, velocity times integral. And so the flow across the aortic valve is equal to the aortic valve area times the aortic valve VTI, and that is going to equal to the flow across the LVOT, which is a cross-sectional area across the LVOT times the VTI across the LVOT. The unknown there is the aortic valve area. And when you put the figures or the numbers in the continuity equation, if it's less than 1, then it's severe. So that is the concept, okay? When you look at the LVOT, you have to measure the LVOT diameter and the flow velocity um, um, or the VTI across the LVOT. And these are areas of potential error, and we'll go over those error. Okay, for the LVOT to reduce the error, you can zoom, increase the size so that you can see accurately where you're measuring and reduce the error right there. Because remember, you're going to square that diameter. So whatever error you got, you're going to square it. Okay. You can use the simplified. So this is the continuity equation where you use VTI. But you can use a simplified continuity equation where you use velocity, and it's usually sort of concordant. It's usually similar, but the real continuity equation uses VTI, velocity time integral. Okay, you know, because the shape of the shape of the different curves vary. The curves varies. So when you just measure a velocity, you don't look at the curve at all. You just measure the velocity, and that's not totally accurate, but you can use it. Okay, but the continuity equation is really the VTI. The flow is similar. Sometimes when you do these studies, you can't really see the LVOT properly. Sometimes there's a lot of calcification, and you know you'll make a lot of error. You can use what we call it's the dimensionless index or the velocity ratio, and what you do, the VTI, of course, you can use the LVOT VTI over the aortic valve VTI, and the VTI again is going to give you a more accurate assessment, but you can use the velocity. So that is the VTI across the LVOT divided by the VTI across the aortic valve. If it's less than 0.25, it suggests severe aortic stenosis. You can use the velocity as well, but it should be the VTI. You can do planimetry of the aortic valve area, especially with you know, you can do it to the transthoracic, more accurate if you do it to the transesophageal echo. The problem though is when you do planimetry of the aortic valve, you get an what we call an atomic. It's an atomic area. When you use your continuity equation and you calculate a valve area, it is it's a ERO that you're calculating, effective orifice area. So the continuity equation is going to give you an EROA, effective regurgitant orifice area, which is not the anatomic area. But it has been shown that the clinical pictures is related to the EROA, clinical pictures. So when we talk about severe AS, we talk about it's the number we have there is for EROA, and that's closely related to the patient clinical picture, not the anatomic area. Okay, so everything we do for valve is based on the EROA. Okay. There are other things that you'll see, the percentage stroke work loss. We don't routinely use those. Just to recap, when you're tracing the jet, you want the modal trace. That's where you have the solid image. Again, you don't want to go to the fuzzy the little fuzzy out here. Okay, so you're going to trace the bold area of the velocity. Okay, so not these little fuzzy things that is right there. Okay, again, the maximum velocity is measured at the outer edge of the dark signal. Fine linear signals at the peak of the curve are uh, owing to transit time effects and should not be included in the measurements. So you want to do the outer edge of the spectral Doppler envelope. That is what you're going to trace. Just to confirm or to stress, if the patient is in sinus rhythm, you need to do 3 or more beats and average them. If the patient have an irregular rhythm or atrial fibrillation, then you want to do 5 consecutive beats. Okay, that is important, and people who are doing exams, they will test you on that. But in clinical practice, you should do that as well. Don't just use one beat and say that's representative of everything. You want to do multiple beats. Another very important point is the shape of the curve. Sometimes we look at the continuous wave Doppler curve, velocity curve that is, and it helps us to talk about the severity of the stenosis and sometimes the level of the obstruction. So let me just draw a few things and highlight that for you. So if you have a situation where the stenosis is not very severe, then you're going to get an early peak. So you're going to get an early peak. So it probably looks something like this. The peak comes early. Okay. So if the peak comes early, it's usually more than likely not a severe obstruction. If you get a rounded peak, like this, then this usually suggests obstruction. Okay, it usually suggests a more significant obstruction. If the obstruction is even more, then the peak will even come later. Okay, so a rounded contour shape of your seat of the curve suggests it takes a long time for the velocity to build up to peak. Whereas if the obstruction is not significant, then you quickly get to the peak. Also, if you want to talk about the level of obstruction, if there's a subvalvular obstruction, then you'll get something we talk about dagger shape thing. It looks like this. So this, and it will be concave like that. You get a systolic concave. So if you see something looking like this, so this is usually an aortic valvular obstruction. So just looking at the seat of the curve, this looks like an aortic valvular obstruction. Something looking like this with a late peak. You can see that this peak occurs late. The time is on the horizontal axis, so this peak occurs late, and especially if it concave upwards, then this suggests some subvalvular obstruction. Okay, so it will sort of helpful when you're looking at these things. So sometimes you just have to look at the curve and make an assessment. So again, with mild obstruction, the peak is in early systole with the triangular shape of the velocity curve, compared with the rounded curve with the peak moving towards mid-systole in severe stenosis. That reflects a high gradient throughout systole. The shape of the velocity curve can also be helpful in determining whether the obstruction is fixed or dynamic. So again, subvalvular obstruction that is dynamic, subaortic obstruction that's dynamic, you get a late peak in velocity curve, which is usually concave upwards. Again, so if you get a more, this is early, this is fairly early because time is on the horizontal axis, it's velocity. So this is not too severe. And then this you can see this is a late peaking curve, late peaking, and then it's concave, systolic concave. And patients with obstructive hypertrophic obstructive cardiomyopathy will have velocity curves looking like this. Okay, late peaking curve. So and you can see the velocity is tremendous, it's very high. So sometimes by just looking at the curve, you can make some predictions. When we talk about pressure gradient, it's the pressure difference between, we're talking about the aortic valve, so pressure gradient across the aortic valve in systole, or the transvalvular aortic gradient, and it is from the LV to the aorta. So if we look at the mean gradient, again, the mean gradient has more clinical significance than just the peak gradient, because the average gradient across the valve that occurs during the entire systole, okay, as opposed to the peak. So it's more clinically relevant. And if you remember your simplified Bernoulli equation, gradient is equal to 4v squared, where v is the velocity, is square the velocity. So where are some of the source of error for pressure gradient calculations? Misalignment of the ultrasound beam with aortic stenotic jet results in significant underestimation. So again, it's a Doppler technique. So you have to make sure the ultrasound beam is parallel to the blood flow. So it's important to use multiple acoustic windows, because remember these are live patients. So if you under calculate the valve area with someone who has severe AS, and they come, say you get 1.5 centimeters squared, and it's really say 0.8, and the patient's having shortness of breath, the clinician who's seen the patient may think the shortness of breath is due to something else, whereas it may be due to aortic stenosis, and that patient can develop significant problems. So accurate calculation is important. And we talk about mixing up your AS jet with your MR jet. you have to know how to distinguish them, and we discuss the look at the shape of the curve. Usually the MR velocity is about 5 meters per second or more. Not we're not saying that you can't get aortic stenosis with velocity greater than 5 meters per second, but if it's 5 meters per second, think MR. Remember, with MR, you don't have the IVRT, okay? So you look at the envelope in its entirety. And, again, this document wants you to understand the concept of flow, how flow will affect velocity, how flow will affect gradient. If you have a situation where the flow is decreased, if the flow is decreased, then the velocity is going to be decreased. And if the velocity is decreased, then the gradient is going to be decreased, because from your simplified Bernoulli equation, gradient is equal to 4v squared. And there are a number of situations that can give you a low flow settings, and we'll discuss those. So it's important for you to calculate the area using the continuity equation. So calculation of the stenotic orifice area or effective aortic valve area is particularly important when the flow rates are very low or very high. So the flow rates can be very high. Some patients who have shunts, patients who have significant aortic regurgitation, patients who is anemic. So anything that can increase the flow can also increase the velocity and the gradient. So you have to be aware of the conditions under which you're doing your calculation and evaluating the patient. So the aortic valve is calculated by using the continuity equation, and we went over that. It is based on the concept that the stroke volume ejected through the LVOT, the left ventricular flow tract, all of that passes through the stenotic aortic valve, and thus the stroke volume at the LVOT is going to be the same stroke volume at the aortic valve. So that's the continuity equation. And so flow again is equal to the area times the VTI, velocity time integral. I'm gonna stress again, the area we're talking about for the aortic valve is an effective aortic valve area. Effective aortic valve area. It's not an atomic area, okay? It's an effective area. So the flow at the aortic valve is equal to the flow across the LVOT, and the flow across the LVOT cross-sectional area times the VTI across the LVOT. And then when you solve for the aortic valve area, you get this. That is the continuity equation. So these are the stuff you need to calculate the valve area. You need the aortic stenotic jet velocity, so you do the VTI. You need your Lvot diameter for calculating the cross-sectional area, and you need your Lvot velocity to get your VTI across the Lvot. But this is a pulse wave measurement. The aortic valve measurement is a continuous wave Doppler measurement because the velocity is usually greater than 1.5 meters per second. So any velocity that's greater than 1.5 meters per second, you need continuous wave Doppler. If the velocity is less than 1.5 meters per second, you can use your pulse wave Doppler. And so the flow, the flow in the LVOT is equal to flow across the valve. Okay, same flow, the same blood is flowing. Okay, now when you're measuring the diameter, parasternal long axis view, And so this is your septum. This is the posterior wall. So this is the anterior. So this is the anterior mitral leaflet. The posterior leaflet and the posterior leaflet is there, and the posterior wall is down there. Your LVOT diameter is a systolic measurement. The reason why you don't see the aortic valve wide open is because it's stenotic. It's calcified. It's stenotic. You want to measure just in front of the valve. Um, the plane should be parallel to the aortic valve plane, okay? And it's from the tissue blood interface. So you, you just go from the tissue blood interface there down to the blood tissue interface right there. There's I don't want to say controversy, but there are some, debate as to where you should measure. But for most patients, the first 1 centimeter in the LVOT, this is usually uh, this is usually parallel. So usually have this is like a rectangle uh, with the anterior mitral leaflet and this portion of the interventricular septum. They're parallel. So for the first 1 centimeter, the measurements are usually the same. So if you want to measure the LVOT diameter here or here or here, you're going to get the same number. The numbers are going to be very, very similar. So the important thing is to make sure that your measurement it's parallel to the aortic valve plane, okay, and it's from the tissue blood interface down to the blood tissue interface, okay. That is the LVOT diameter. So although we assume that the LVOT is circular, um, when we look at three-dimensional studies and CT, it is not really circular, it's more elliptical. But since we're using a mathematical formula, the area for the area for a circle is pi r squared. So pi r is diameter divided by 2, and you square that. So if we're going to do our LVOT VTI, the pulse Doppler sample volume is positioned just proximal to the aortic valve. When the sample volume is optimally positioned, the recording shows a smooth velocity curve with a well-defined peak and narrow band. You don't want to be too close to the aortic valve because you're going to get turbulence. And turbulence is going to falsely increase your LVOT VTI. So you want to get outside of that zone of flow convergence where you have laminar flow. And that's where you want to measure it. So if you get a VTI approaching 30 centimeters, you're too close. The usual VTI is between 18 and about 26. So if you're getting anything approaching 30, then you're too close. So this may not be the case in many patients with significant AS when the sample volume is positioned at the annulus owing to the flow to flow convergence resulting in a spectral dispersion level. Essentially, you don't want to get too close to the valve. You want to get outside of that area, laminar flow. And this is what you want to get. So your two-dimensional echo is on top, apical 5-chamber view, and your sample volume is, so this is your cursor going straight across the aortic valve, but your sample volume is right there, a little distance away from the aortic valve. And you want to get a nice smooth curve like this. Okay, this is your LVOT curve. And then when you do your planimetry, it should be a modal curve thing. Okay, just trace it and get that. So again, you can get flow acceleration at the annulus level and even more proximally. It may occur more proximally. So in some patients, you may need to move it to about 1 centimeter away, so you get laminar flow and you don't get that spectral dispersion. Do not position the sample volume too close to the aortic valve. If you get in VTI approaching 30, you're too close. Another situation is you do your parasternal long axis view and the patient have a lot of calcification. If you just change your angulation a little bit, you can get where you can see a nice Lvot diameter to measure. In this case, you can't measure anything. There's a lot of calcification. But just by doing a little angulation of your transducer, you can get a nice Lvot diameter. It has been shown that clinical measurement variability for the continuity equation, the effective area depends on the variability in each of the 3 measurements. Okay, the variability when you're going to get the aortic stenotic jet and the Lvot velocity. For the aortic jet, there's not much variability. If you use multiple windows, you're gonna get your maximum velocity. It's gonna be pretty close. Whether it's the same person doing it or another person doing it over. The aortic jet, you don't usually get a lot of variation. There's more variation with the Lvot velocity. That's where you get a lot of variation. Well, not a lot. It's about 5 to 8% variation. So there's more variation with the Lvot measurement. Again, the area that we calculate is the effective aortic orifice area. It is not the anatomic area. Most of your error is going to occur when you measure the Lvot diameter, and that is why you need to spend some time, trying to get the Lvot diameter as accurate as possible. Remember to zoom to reduce the errors. As we showed before, the original continuity equation used the VTI. Okay, use the VTI. You can use velocity. It is not the same thing because the VTI use a curve. It uses a curve, and even though you might have the same velocity, the curve may be different. So the VTI is more accurate, but you can use velocity. Okay, so you'll see that. So you can use the velocity, and we talk about the velocity ratio. So severe AS, if it's less than 0.25, the dimensionless index. So that is the Lvot VTI divided by the aortic valve VTI. If it's less than 0.25, suggests severe. Again, planimetry measures the anatomic area, and what we usually talk about is not the anatomic area. So the grading, so we did all of this to grade the severity of the aortic stenosis. So we use the velocity, we use the mean gradient, and we use the valve area. Those are things that we use to talk about severity. And again, for severe aortic stenosis, peak velocity greater than or equal to 4 meters per second, the mean gradient greater than or equal to 40 millimeters mercury, valve area less than 1 centimeter squared. And then for small patients, you can index. So not for all your patients, but for small individuals, you can use an index. And if the index, what you're doing is just dividing the valve area by the body surface area. And if the aortic valve area index is less than 0.6, then it suggests severe aortic stenosis. The dimensionless index or the velocity ratio less than 0.25 suggests severe aortic stenosis. All you need to remember now is mild. So the peak gradient, the peak velocity in mild aortic stenosis is about 2.6 to 2.9. The mean gradient is less than 20. The aortic valve area is usually greater than 1.5 centimeters squared, and the velocity ratio is usually greater than 0.5. So these are the situation for mild aortic stenosis. For severe, anything that falls in between these two, then it's moderate. And there's a condition we call aortic sclerosis. So when you look at the valve, it may be thickened, maybe a little bit calcified, but the velocity is less than 2.5 meters per second. Less than 2.5 meters per second. So this is what is expected. But if you have someone, you do the continuity equation and the valve area is less than 1 centimeters per second, but you're getting mean gradient less than 40, or you're getting velocity which is less than 4, then things are not lining up. And the next few lectures, we're going to look at those situations. And, one of the things that can give rise to that discordant situation is when you have low flow and hence low gradient airs. So the next few lectures will look at low flow, low gradient airs. Okay. All right. So we're going to stop here and continue on Thursday. Okay. All right. Good night.